I'm going to talk particularly from UCL Partners because that's what I know most about. But I think pretty well everything I'm going to say will be the same for the other two academic health science networks. The details will be different because the geography is different. But Chris Strether is here, so he can tell us if it's the same south of the river. Now, academic medical centres were invented at the end of the 19th century in America to bring together in a very close alignment the culture of research, education, high-quality care in relation to a hospital. And the oldest and most famous is the Johns Hopkins Hospital. And they've metamorphosed into health systems, into partnerships, and most recently in this country, into the notion of an academic health science network. They were driven towards a network by the realization that UK PLC was not actually generating the sort of income out of wealth creation from its inventions in pharmaceuticals and medical technology, and more needed to be done to speed up the translation from the idea to clinical success into population benefit, both in terms of the health of the people, but also the wealth-creating opportunities. And so the paper or the government publication which announced them said they will present a unique opportunity to align education, clinical research, informatics, innovation, training, education and healthcare delivery. UCL Partners serves the northeast and north central London, part of Essex and Hertfordshire, and we cover a population of about 6 million people. We can cover 26 local authorities, 14 higher educational institutes and so forth. Now, the first thing to say about us is we don't own things, or at least we try not to own things. We try not to be important, and we try not to be powerful. Because if we become important and powerful, then we'll cease to be able to do what we do, which is to facilitate between people. Somebody said to me once, what do you think your job is as chairman of UCL Partners? And I said, I am a cross between an academic dating agency and ACAS. That's what I do. I encourage people to talk to each other and to find ways in which they can move forward together. The translational gap, that is the gap between the idea in the laboratory into clinical success through trials and thence into population benefit, is referred to in various publications in various terms. I'm going to use gap 1 for the translation from basic discovery into clinical success, and gap 2 into population benefit. And UCL Partners, when it started as an academic health sciences centre, before it became a network, was mostly concerned with integrating the biological research centres, the pathway from basic discoveries to clinical trials, but then how do we take it into population benefit? So we integrate across this pathway from the academic health science network, across clinical research, across clinical research into the network, into applied health research, and then into outcomes. So education is an important part of our relationship, so we relate very closely to the Local Education and Training Board, the LETB, that covers our geography. This is a simple example of a monoclonal antibody which was developed for the treatment of multiple sclerosis at the Research Institute of the National. It then went through clinical trials. It then went into implementation, evaluation, which was quite important because it showed it had some quite serious side effects. But it's now gone out into benefit in the population and is part of training and education. So that would be an example of a case study for a preparation. The difficulty is that on average it takes 17 years, this is the accepted figure, for something which is proved to work in practice to actually get into population benefit. And there are many examples of that, whether it's the prevention of venous thromboembolism or the treatment of peptic ulcer with antibiotics as opposed to having your stomach removed. And people have tried various ways of actually getting innovation to happen, and and I'm involved at the moment in this one, dissemination, though nobody's actually fallen asleep yet, but time will tell. And it's no use shouting. We think the only way to do it is actually to encourage people to work at it together. And so some examples. Now, this is an important one. It covers the whole of London, and the man who actually drove this forward is sitting at the back there, Chris Strether, because it was something that came up from the clinical advisory group for NHS London after the framework for London was published. The research was clear. The question is, how do you make it happen in practice? And as you know, there are 8 stroke centres in London, and they are all integrated. The ambulance will take you there to one of the 8 stroke centres, and as long as you get your thrombolysis within an hour, 3 hours at most, it can have a dramatic effect on the survival and the quality of survival. And what is, I think, very interesting here is the cost. There was an investment that was required to make this happen. But the cost saving from the recent economic evaluation shows that it is quite significant. Quality comes cheap. If you get things right first time in healthcare, you save a lot of money and you save a lot of disturbance for patients. We are now working, this is UCL Partners, and I imagine they're doing the same in the other 2 academic health science networks, is how do we actually integrate other services, cardiovascular, for example, and cancer. Each jurisdiction is different, but for us, it's how do we get an agreement between our 2 major providers, which is Barts Health and UCLH, to have a single large specialist centre and to look at the whole pathway to the prevention within the community to the high quality care in hospital. So our task at UCL Partners has been to play our part in facilitating an agreement between 2 very independent hospitals, St Bartholomew's and Barts Health in London and UCLH, to agree to a single heart hospital, which hopefully will go out to consultation shortly. Likewise on cancer, to concentrate specialist cancer in one site, which will be UCLH, so that we get better outcomes for the treatment of cancer. But of course, the real problem in London for cancer, as Sunday referred to before tea, is diagnosis. It is shocking how many people are diagnosed with cancer from attendances in the A&E department. And what's even more shocking is they normally have to go there 2 or 3 times before they do diagnose them as having cancer. I feel particularly strongly because I used to be a paediatrician, because the outcomes for children are dreadful in relation to the rest of Europe. Children are simply not diagnosed early enough, and they do not survive as a result. So we are interested in an integrated cancer system across the whole of North East and North Central London, and that's something that we facilitate. We don't do it, we facilitate it. Likewise for mental health, we have 5 main programs in our academic health science network. You've heard about cardiovascular, you've heard about cancer. Neurosciences, that's the stroke, and there are other things within that. And the 2 others, 3 others, mental health and long-term conditions, which include women and children, and multiple comorbidities. Mental health is a huge program for us. There's a very large number of institutions and activities within that jurisdiction. And it's no accident that the conference we organised 2 weeks ago in London on the future of health was co-organised between our mental health programme and NHS England, because mental health is the commonest comorbidity of all long-term conditions. But they also have their own programmes. This is just an example. This is a huge trial of multisystemic therapy, psychotherapy, in young people with conduct disorders to see if we can reduce the burden of dysfunctional behaviour in teenagers before they reach adult life. So this is the sort of thing we do. One of the most interesting to me, because it was entirely generated from the ground up. I mean, I should declare prejudice in that I don't believe you will transform healthcare in London unless you do it from the bottom up. This was from the bottom up. This was a number of hospitals within UCL Partners where the medical directors and the nursing directors launched themselves an initiative to reduce cardiac arrests. And by identifying deteriorating patients and putting in early intervention, they have dramatically reduced cardiac arrests. I mean, just look at the figures. And not just UCLH, which everybody sort of knows about, but at the Whittington, at Barnet and Chase Farm, and other hospitals. And this was all doing it differently, but to a common sort of template, meeting together, but with a central organisation of the data, which was carried out at Great Ormond Street. And that's been a huge success, and I'm very pleased about that, because it's something, as I say, that came bottom up. Now, what were we told we had to do? Well, we were absolutely told that we had to do something about trials. We pride ourselves for the National Health Service as being the place that Big Pharma would want to do business. And the answer is they don't want to do business here. The biggest contract research company in the world, Quintiles, employs more people in Poland than it does in the United Kingdom, and that's just a fact. And getting approval for trials is extremely difficult because of the need for all the partners to sign it off. So getting single sign-off, as it's called, and improving the efficiency of clinical trials is an absolute requirement placed on us as Academic Health Science Network. Well, we have now got single sign-off across our jurisdiction, and the number of trials has increased hugely. There are some trials which Big Pharma is not going to do in this country anyhow. It's much cheaper for them to do it in other economies. But as you go into personalised healthcare, stratified medicine, where you bring genomic and epigenomic information alongside the development of the pharmaceutical agent, then we ought to be able, using our network, particularly as we move into organisation in primary care, which I'm going to come to, we ought to be more efficient than most other places. I mean, as Mark, I think it was Mark said before tea, the great strength of the British National Health Service is the registered list. And if we can actually really develop that in this area, it could be quite effective. Now, that's the sort of background to what we do. So what is the problem in terms of population? This is where I link in to what we were talking about before tea. This is data, as you've probably seen it, from Scotland. I have to admit that within the United Kingdom, Scotland is the most unhealthy part of the country, of the UK. But people of my age in Scotland, where are we? Yes. The majority of them have at least one long-term condition. And if you come down here, about 50% of them have three. And so it's not a question of how do you manage a long-term condition, it's how do you manage the patient with the long-term condition, because they will have more than one, and the context of their lives is important as the management of it. So we've been trying to address ourselves more and more to how do we deal with that. And just three examples. This is some work we did with young people with diabetes. I used to be a paediatrician, and I knew that we failed young people with diabetes. People with type 1 diabetes, of which there are 2,000 roughly in our jurisdiction, by the time they reach adult life, they are destined to go blind and to go into renal failure. Because glucose is a poison, and if you don't manage your blood glucose through the turbulent years of adolescence, by the time you get to the age where you will manage it, it's too late. And doctors and nurses, be they paediatricians or diabetologists, have singularly failed to achieve their patients having the level of glycemic control which is necessary to prevent the complication. But a diabetologist, Peter Hindmarsh at UCL and GOS, came up with a way of developing a system where the young people manage their own diabetes. So we went to Microsoft and developed a system for them to have their own record, which is they can interact with all the people who can provide help, they can create a social network, and they can take responsibility for managing their own disease. And it has been successful within his clinic. As you can see that the median glycosylated hemoglobin level is 7.7. Success is around 7.5. And you can see it's quite a lot better than elsewhere. And actually the best place of all, I'm told, is in Berlin, but that is the standard. So we are now spreading this methodology across the whole of UCL Partners. Likewise, we did a study on people with COPD. That was a bit of a surprise, because we had this idea that we could take a population of people with COPD and we could measure their health status, apply the NICE guidelines and measure it again. And we thought it was fairly straightforward. And it happens in Barking, Redbridge and Havering and Redbridge. There was 20 general practices where we had all the data to measure the year in the life of, the cost of the care over a year and the outcomes. So we thought we'd just apply that. So we got some money from the Department of Health and we started. And it turned out to be nowhere near as easy as we thought, because it turned out that half the patients who were identified with COPD didn't actually have COPD, and half the patients with COPD were unknown. And then it got worse, because the way you diagnose it is using a spirometer, and we found that most of the practices didn't own a spirometer, so how they diagnosed wasn't quite clear. And those that did, in one case they hadn't opened the box. But they didn't know how to use it, so we had to go in and start training programs. Anyhow, so it was a bit late, but we got there. And what we found was that the cost of managing COPD rose, plateaued, and then began to come down, because fewer patients were going to hospital. And a lot of this was self-management. And that, of course, is the way forward. More self-management, more home care. So our notion about UCL Partners is that it works on shared values, strong partnership working, and so forth. What it doesn't do is depend on control. And that is the sort of thing we do for outcomes, which is look at value in terms of clinical outcome measures divided by cost. Now, just to end with, in relation to what we were hearing before tea, unless we reimagine healthcare in terms of the social determinants and the management of chronic illness, we are going to find it very difficult to cope with the next years. And so one concept that we're interested in is the notion of the community hospital, what the Americans call a medical home, or the house of care that Martin McShane talks about. And the sort of thing that Sam Everington has developed over the years at Bromley by Bow, somewhere you go for social interaction, develop social capital, to develop your community, to improve your health, not just health care. And it so happens that we heard today Newham has the highest birth rate in England. I didn't know that until this afternoon. But the 4 Olympic boroughs, there's 6, but the 4 really poor ones are scattered around the Olympic Park. And at the Olympic Park, there's a fantastic medical centre, which is, of course, emptied after the Olympics. Wonderful design by Penroy and Prasad. And so we want to turn this into a community hub, and we think across London there'll be many more of these. And somewhere you go to coordinate health and social care and community services. So the proposition is quite simple. We face a syndemic of chronic illness. We need to design healthcare systems based in the community, health and well-being boards, networks of GPs, social service community, serving population around 25 to 100,000, 50 to 100,000, the Ed Wagner's chronic disease model, and they should be designed to promote health as well as to provide health care. And we want to use those also as a means to fulfill our mission for GAP 2, which is population benefit, to trial health improvement science. So we will have a basis in the Ludwig Guttmann Centre. Our new professor at UCL of Health Improvement Science, Martin Marshall, will be based down there. And we will have researchers based there working alongside the population to find new ways of approaching the improvement of health as well as the improvement in health care. So that is one of our ambitions which is going forward.